Good afternoon. I'm Veline LEsperance. I'm an academic general practitioner. I'm based in Southeast London, and my academic institution is King's College London. I'm also a clinical advisor to the NHS Race and Health Observatory. So today I'm going to talk to you about how using economics we can reduce health inequalities within the primary care setting. Essentially, general practice, as many of you may know, is the bedrock of the National Health Service and the setting for over 90% of all patient contacts, with over 300 appointments in 1 year. However, it accounts for just under 10% of total NHS spend. General practice combines medical expertise with a deep knowledge of local neighborhoods and is therefore well placed to tackle health inequalities. And policy makers expect general practitioners and GP practices to play a central role. However, it's well publicized, essentially, that within general practice, there are many, many challenges. These range from workload, difficulty in recruiting and retaining workforce, inequitable access, and patient outcomes. However, these inequities were apparent way before COVID, but unfortunately, COVID has perpetuated these. We also have inequitable funding to general practices. So here's a few things to consider for this seminar. Does greater investment in primary care improve population health outcomes? There's also a gap in knowledge in the measurement of primary care performance. And the mechanisms by which primary care outcomes influence patient outcomes are very important. Essentially, there are varying ways in which practices staff their practices, access, consultation styles, and quality of care. And this heterogeneity essentially plays a role in the variation of outcomes across general practices. And they're also influenced by local and national policies, which may not only produce health inequities, but continue to perpetuate them. So this slide shows how funding to general practices work. So on the left, we see that between 2013, the per patient funding was about £136. So that's it, £136. Patient can come to the practice as many times as they want if they can get an appointment, and that's what you're all thinking. Managing chronic disease, vaccinations, £136 in 2013. And that's come up to about £164 per registered patient in 2022, 2023. But obviously that has not kept up with inflation. If it did, it would be around £182. On the right, I show how funding is distributed. The majority of the funding comes from what's called the global sum. That makes up 47%. I'll talk about that in a bit next. We also have what's called QOF payments. Many of you may be familiar. It's essentially payment for performance. So getting a patient's blood pressure within a certain range. And if you have 90% of patients hitting that target, you get paid for it essentially. And that makes up 8.3%. Historically, that used to be as large as 25%. We then have what's called PCN funding. So that's primary care funding, making up 6.7%. That's essentially where practices get together and look after a patient population of about 50,000. And that was really put in place to help with health inequalities. We'll talk about that later. And also workforce challenges as well. So having what's called additional roles, things like pharmacists, physiotherapists, physicians, associates, some of that funding comes from the PCN. We have prescribing and dispensing payments. We then have premises payments. So for example, you need your practice refurbished. There's some payments that can help with that. Historically, there also used to be payments that helped with things like interest rates payments for mortgages. We then have local incentive schemes, 5.8%. So that's really about two things: access, so extended access to general practices where you share that with your local area, and then also things like incentives based on what are the immediate problems within your general vicinity. So things like mental health, for example, is one that we do. And then you have your direct enhanced services. So that's things like your vaccinations, for example, minor surgeries as well. Okay, so here we look at the global sum. Now remember, this makes up about 50% of total general practice funding. So essentially, what you have is that there are two main drivers that sort of push this global sum. The first is drivers of workload, yep, and then the second is drivers of unavoidable costs. So here you have things like the Carhill formula, where you use a weighted formula for your patient list. And it's been criticized essentially for not sufficiently in this day and age taking the impacts of deprivation. So the most influential factor for the Carhill formula is your age-sex distribution of your patients. So for example, a boy aged 14 would be 1, whereas a woman age 85 would be 6.2 as an example. Other things that drive it are morbidity and mortality of the practice. So again, if you have a very morbid population with lots of chronic disease, that drives up the formula. And then list turnover. Essentially, a new patient joining your list can essentially cause, or it's thought that they may cause, increased workload for you as a GP for the rest of the year. So there's some costs associated with that. And then you get a payment for the distance in which your patients live away from the practice. So that really is a rural factor, yeah? So for where the distance from the practice doubles, that increases the global sum by about 3.5%. And then you have market factors. Running a practice in a big city will cost more than possibly running it in a small village. So there's some factors that are associated with that. And then the loss is really self-explanatory. If you have a practice that looks after lots of nursing home or residential care home patients, then there's some weighting that goes on to that as well. So essentially using this formula then essentially prepares a weight, and then that's added or multiplied by the number of patients you actually have registered at your practice. So we'll start by looking at whether there's a relationship between general practice funding and patient outcomes. I start by looking at the relationship between general practice funding and care quality outcomes. So all general practices and hospitals, but today we're focusing on primary care, are subjected to inspections by the Care Quality Commission. Essentially, there are 5 main domains. Is your practice safe? So that's in terms of safeguarding, so adult safeguarding, children safeguarding, medicines management. Is it effective? So are you providing evidence-based treatment? What are your team working skills like? How is monitoring of patients done? Is it caring? Is your staff, when the patient books an appointment, are the receptionists nice, respectful, compassionate? Are the clinicians giving the patient privacy and dignity? And is your practice responsive? So are you providing patient-centered care? How do you deal with concerns and complaints? And do you provide timely access? And then last, is it well-led? What's the leadership like within your organization? What's the culture? And how do you manage risk and performance? So for each of these 6 domains, we then have essentially 4 outcomes: outstanding, good, requires improvement, and inadequate. So the vast majority of practices are good, probably about 3/4. Then you have about 4% that are rated outstanding. So that's really a coveted sort of badge of pride that you're sort of providing outstanding service. And then inadequate. Inadequate is, well, it says what it does. Essentially, the service is performing badly. And most importantly, it means that your practice, is at risk of closing down over the next 6 months. So there are things you would need to put into place and remedial action that would need to be taken when it's reviewed 6 months later. So to explore the relationship between general practice funding and quality ratings, we looked at 7,310 practices over a 3-year period. So on the left, we showed a distribution of ratings across each quality domain in figure A. So about 79%, like I said before, are rated good, while about 4% achieving outstanding. Inadequate rate is varied across the different domains and ranges from about 1% in the caring domain and 6% in the safety domain, and then about 4% overall. So in figure B, it shows how practices who are rated inadequate versus those that are rated outstanding. As you can see across all of the domains, those practices which are rated outstanding essentially receive the higher capitation funding compared to those that are inadequate. And that's really across the board. And that shows significance in all of the domains except effective and responsive. So we use ordered logistic regression models to calculate the probability of achieving an outstanding or an inadequate rating across each of the different levels of capitation funding. In A, it shows the average predicted probability of achieving an outstanding rating for a range of different capital levels. The probabilities are on average. Estimate the probabilities of each practice calculated at each level of funding. So as you can see, for those rated outstanding, the more capitation funding you have, the higher probability of you getting that outstanding rating. And then the opposite is true for those rated inadequate. Essentially, where you're more likely to be rated inadequate. And then we looked at different levels of funding based on different types of practices. So in figure A, we have training practices versus non-training. In B, we have group practices versus single-handed. So single-handed means that they're run by essentially one GP, but other clinicians may also be in the practice as well. And then rural versus urban. So in A, we see that training practices essentially are more likely to be have higher ratings and have higher funding rather than non-training practices. The same for group practices, more likely to achieve an outstanding rating compared to single-handed practices. And then the same for rural versus urban as well. And that's at each level of funding. So using retrospective longitudinal data, we also looked at patient experience from 2013 to 2017 to really understand the relationship between general practice funding and patient-reported experience. We used the patient experience data from the General Practice Patient Survey, and that essentially had 6 domains: overall experience, access, continuity, professionalism of the GP, professionalism of the nurse, and also professionalism of the reception staff. So this figure shows the difference in funding for practices within the highest achieving quintile of patient experience compared to practices within the lowest quintile. In each domain, practices in the lowest quintile receive significantly lower mean funding. So for example, the mean total funding for practices in the lowest achieving quintile for access was £121 compared to £150 for the highest achieving quintile. And the mean access scores were 50% compared to 71% respectively. So this table shows the association between practice funding per patient and the 6 different experience domains. So all models of funding was positively associated with patient experience, and the association was statistically significant. So the model implies that a one standard deviation increase in mean funding gives you is associated, with a 0.88% improvement in practice experience in the following year. This is also true for the current year as well. So the same is true for the same year and also for the year after. So it's almost like you have invested in the practice in one year and then you reap the benefits of those in the subsequent year. And you build on that success, possibly, unless there is some sort of shock to the system. Similar results were seen for patient-reported quality of life scores. So in this GPPS question, there were also EQ5D questions as well. This has since been removed from the GPPS survey because they felt that it wasn't very valuable. So essentially, self-reported quality of life questions, all of and the domains in terms of your state of health, in terms of mobility, self-care, usual activity, pain and discomfort, essentially was shown to be associated with increased funding for the practice. So all of this data is at practice level, all right, except for anxiety and depression. So here's just a summary of findings looking at clinical achievement and how it relates to general practice funding. So blood pressure control, there was greater achievement in higher funded practices for hypertension, stroke, diabetes, and peripheral vascular disease. There was also greater achievement in well-funded practices that they had better glycemic control, so better control of your patients with. So other factors include influencing higher clinical achievement are things like a proportion of older patients. You sort of get better at essentially doing these process measures, because that's essentially what they are, measuring a person's blood pressure, tinkering with their medication. You get better at it. Group practices also performed better, and practices which provide postgraduate training. So that's essentially a training practice that trains the next generation of GPs, mainly because, like all practices, they undergo CQC inspections, but they also undergo additional inspections from Health Education England to ensure that your GPs, that the practice is a good learning environment for doctors. And we don't only see in postgraduate training practices, it's not just GP trainees, but we also have F1s and F2s, so junior doctors. And also lower patient size growth. So this turnover, having less of this turnover was associated with higher achievement, because you're not having these new patients come in that disrupt your system. You sort of have the same patients, you know them each year, you're able to sort of meet those targets. We also looked at primary care mortality at practice level, and essentially higher funding was associated with reduced practice mortality rates for all-cause mortality and premature mortality, people dying under the age of 75. So other characteristics associated with reduced mortality, less deprived population, so practices that are in more wealthy and affluent areas, increased patient experience scores, happy patients, how reduces mortality, and then the U-shape. So these are extremes of age. And then if you're in receipt of what's called a capitation supplement, this was unfortunately phased out a few years ago, so it's not currently included in the funding. But essentially, practices used to receive what's called the mean practice income guarantee. When the contract came in 2004, in order to sort of deal with the shocks of having a new contract come in and disruption to your funding, there was a supplement that practices got that allowed them to maintain the level of funding that they had before. So previously, for example, prior to 2004, you could have been funding your practice and having additional services that you then costed for. Yep. So the thought is that these particular sort of MPIG practices are those that possibly went above and beyond and provided additional services for their patients. And these were also tended to be in more affluent areas. And then finally, mortality harvesting, higher mortality in a year was then associated with lower mortality in the following year, because your most vulnerable patients would have died essentially. Looking at secondary care utilization, so higher funding again was associated with reduced A&E, with reduced emergency admissions, outpatient, and also ACSC admissions as well, but not associated. But higher was found with A&E attendances. So the first part of this talk, I described how general practices are funded and the possible relationship that funding plays in terms of patient outcomes. So now let's have a closer look at inequities in primary care. 50 years after it was first described, the inverse care law, it still persists within general practice. We know that general practices in areas of higher areas of deprivation where health need is at its greatest, are essentially underfunded and underdoctored. Okay. We also know that in socially deprived areas, work from Gupford essentially showed that there were shorter consultations in socioeconomically deprived areas compared to wealthier areas, despite having these patients having more health need. And work from the Health Foundation has shown that GPs working in a practice serving the most deprived patients on average are responsible for about 10% more patients than GPs serving in less deprived areas. And this is even after adjusting for need. Work from the Health Foundation also found that once weighted for need, that's GP workload, they found that in 2018-19, practices serving more deprived populations who on average had greater need received 7% less funding compared to those in more affluent areas. Yeah. And then we see that the number of practices on the right being run by a single-handed GP essentially are quite high in the most deprived areas compared to the least deprived areas. So essentially you have these single-handed practices in the most deprived areas with patients having the most complex needs, seeing these patients. So further work from the Health Foundation has also demonstrated that practices in deprived areas have lower care quality commission scores, also have lower performance, so that's your clinical achievement, and have lower patient experience scores as well. So going back to secondary care utilization, we also noted in our own work that patient deprivation was associated with higher emergency admissions, and other studies have found the same. So now let's look at provision of additional services within general practice. So primary care in England is contracted to provide essential services. That's your global summit. That's what it's there to provide. But practices also provide additional services called directed enhanced services. You saw that on one of the previous slides. And this provides essentially extra income, but it's optional. You don't have to do it essentially. Yeah. An optional nature obviously then results in equitable service delivery. So these DES, they're defined in terms of activity level and measured as the total DES funding per patient. So essentially, on the left shows the different directly enhanced services, influenza and pneumococcal vaccinations, shingles vaccination, meningitis, childhood vaccination, pertussis, learning disability health checks, minor surgery, extended hours, violent patients. Yes, there is a practices that do that, and out of area care as well. So essentially, there's activities offered by about 99% of practices, and in 2018-19, this was about £6.25. This is reduced quite significantly since then, because that funding has been eaten up by something else, by PCN funding. I'll go on to that next. So what we do know is that the mean DES payment was lower in the most deprived areas compared to the least deprived areas. So that was about £5.96 compared to £6.55. You may be thinking, these are quite small numbers, but when we're thinking about £140, £150 per patient, it actually is quite a significant amount. So here we see that essentially in the most deprived quintiles, they received about 35p per patient less compared to more affluent areas. Yeah. And higher DES funding was also associated with a higher proportion of children aged 0 to 4. You can hit targets if you have a large, a proportionally large population of children that need their vaccinations done, and was also associated with other funding sources. So higher QOF payments, really important. If you have a well-oiled machine, you know how to manage your patients with chronic disease, then doing these additional things. Again, you have probably your administrative staff that are in place to do that. You have your text messaging systems set up. So again, all of that then influences these other payments that you may receive. And also interestingly, higher desk funding was also associated with lower capitation fees. So is it that these practices are trying to possibly make up for the funding that they're not getting through the global sum? Yep. And also, if you have a younger population for some of the DES measures, then again, that could be influencing the capitation fee. So further modeling of the demographic and practice determinants conducted for the individual components of activity. So we looked at essentially each of the different DESs. And as you can see, essentially, social deprivation was associated with lower DES activity across each of the different domains, except minor surgery and violent patients were significantly associated rather. Yeah. So we also see, really importantly, and we'll touch on this later on, is that for patients that are of Black ethnicity, essentially the higher proportion of patients you have from Black ethnicity background, you then have lower vaccination activity for childhood vaccinations, and also lower pertussis vaccinations in pregnant women. So that's really significant. But then you also have positively associated with extended hours of access. Yep. So again, people can't necessarily come during normal times, so then they seek out of hours service.
Okay, what's the units on those pieces?
So these are actually it's converted to pounds, so it's pence. So this then brings us on to the NHS long-term plan. Yep. So further development of the DES scheme in 2019-20 saw the introduction of the long-term plan, which was aimed to allocate funding to general practices for working in networks to collaborate with other practices in the achievement of specific population health initiatives, cardiovascular disease management, enhanced care in care homes, medication reviews, and so on. It was also put in place to help to address health challenges in terms of addressing health inequalities, and also put in place to address workforce challenges. So within my practice, I'm part of a PCN, and I have PCN pharmacists, for example, who do all of the chronic disease management for 3 of our practices in the area. High blood pressure, asthma, high cholesterol, they do it essentially, and they help to drive chronic disease management in that way. Yeah. So then the DES I spoke about before also provides these PCNs with extra resources in addition for the delivery of these additional services. So this is work out of Manchester, exploring whether primary care networks could essentially contribute to the national goal of reducing health inequalities. And what they found essentially is that over the 4-year period, a 10% increase in deprivation was associated in 31 cents less funding per weighted patient. But in 2022-2023, this same increase in deprivation resulted in 16 pence more. So essentially, there's been a shift, a slow shift, very little money, but a shift nonetheless. So it sort of paints a bit of a positive picture that essentially some of these policies are starting to go in the right direction, essentially. Though small, it is still significant. So how do we tackle health inequalities locally in our practices? So the contract specification for the PCN requires that PCNs formulate a co-produced plan to tackle important locally identified issues. So within my PCN, we created a specific health inequalities dashboard. That's what you see now. So when you log in to our dashboard, and this dashboard helps with everything. It helps with all the additional activities and also monitoring your QOF performance. Yep. So then you can decide how to tailor your services depending on where you are in the year. So this health inequality specific dashboard was created by Tariq Radwan, one of our lead GPs, essentially. Yeah. And it was really important. This was important because we wanted to try and identify which patients are underserved, which patients should we be focusing our efforts in, essentially. And this allowed us to pull data, routinely collected data, and some that we also took from within the practice as well, to identify where these sort of pinch points are. So when you click on the dashboard, this is what you get. And these were the areas that were raised as major concern. No one said, these are what you should focus on. Locally, these are things that came up that was thought, we need to focus on that: diabetes, heart disease, hypertension, chronic kidney disease, strokes, TIAs, cancer screening, very important, childhood immunizations, adult immunizations. And also then looking at the different communities we have across all practices. What languages do they speak? Are we meeting their needs? And this sort of dashboard allows you to do that. Most importantly, this dashboard is not just for clinicians, it's for the administrative staff as well. So everyone takes a keen role in knowing how and whether you are sort of helping to reduce health inequalities across your local patch. Okay, so the areas we decided to focus on in terms of people or communities we felt were being underserved were those from Asian and Black ethnicity, those with serious mental illness, and those with learning difficulties as well. So I'll just talk you through one particular project we did within the practice. And essentially, we're based in Lambeth. We have over 300,000 residents in this particular area. A quarter of the population in Lambeth live in poverty, but 43% are Black, Asian, or multi-ethnic. And Black African, Black Caribbean, Black British account for about 22% of the population. So there's wide variation in health outcomes across the Southeast. And these outcomes have essentially declined since COVID. They were there before, you didn't see them, but they declined even more since COVID. Yeah. And of course, this has exacerbated health inequalities and also led to this wide variation in blood pressure control. As we spoke about today, COVID sort of perpetuated this shift in trust of healthcare providers, of the institutions. So again, not only did that affect vaccination take-up, it's also affected chronic disease management, okay? So for our PCN, we have 45,000 patients, and about 3,000 of these patients have hypertension. So essentially, we wanted to deliver improved hypertension outcomes and to narrow the inequality gap between Black and white patients. Really as simple as that. And that's a message that a clinician can understand and a receptionist can understand. We had disparities. We now need to find out why, and we now need to address them. So the best approach we thought was using a data-driven approach. That way you can check your progress. Everyone takes responsibility and is accountable for these measures across the practice. So within this, we had, as I showed you before, the health inequalities gap and the health inequalities, app. And essentially, this is a population health management platform that puts data from a wide variety of sources, but we also wanted to make sure it was easy for anyone within the practice to use, okay? So it incorporates performance data sets from various different systems, EMIS, System 1, Vision, and also uses nationally routinely collected data from QOF, the National Diabetes Audit, as an example.
Right. Could we just have a clarification on the previous slide? What the key on the graph was?
So this is just showing the level of deprivation in different areas. Yeah. So, and it's showing Lambeth, which is red. So very deprived. I don't know if
In the sense.
in the sense. Yeah.
Thank you.
You're welcome. All right, so here's where we started. Essentially, prevalence of hypertension across our also white population was about 13.5% at 37%, and across the Black population was 5.3%. But nevertheless, we had an inequality gap of 12%. So we weren't managing our patients from this particular ethnic background very well. And we can go through, you know, potential reasons why that may be, but nevertheless, it was there. So essentially, we had some work to do, because although on the face of it, our QOF scores were great across all practices for delivering blood pressure control as a whole, when you looked at the data, when you looked at who the patients are that you're managing, then this clear disparity could have been seen. So then essentially through various workshops with our clinicians and with our pharmacists, and really it took a lot of effort and work. And I think we discussed this about earlier today about, you know, if you have to then target certain communities, you then have to invest sometimes more time and resources to get that done. And that was the case here for sure. But after 12 months, we're able to, you know, essentially get rid of that inequality gap, but also on the basis of that, also improve hypertension management across both groups. So although we didn't necessarily target people from a white background, their blood pressure control also came up because there was something that we were doing across the practices. Yeah. Essentially, when this first started, it was decided that there was going to be no additional money. There was no additional money you could only use the pot that you were given from NHS England, yes? So there was no additional funding, but it did mean varying your resources to different things, yes? So where you might sort of decide you're going to tackle, I don't know, shingles vaccinations over the next 2 months for your QOF, you may say, well, actually, I'm going to ease up on that and then let me sort of put the effort into blood pressure control, as an example, in this particular group, because there was this inequality. So it's about not necessarily having more funding, but also using your resources in different ways that match your population, I suppose. How can health economists sort of help, I guess, change primary care more on the ground rather than sort of larger national change straight away is difficult, but there are pockets of good activity all around the country. But unfortunately, a lot of this good activity isn't necessarily being costed and we don't know the value of it. And therefore, if we don't know, then we can't sort of then put those different pockets of change into policy. And I think that's where health economists come in. So just showing you a little bit more about this dashboard. So the top sort of tells you where you are in terms of your QOF performance. It's May, so it's early, so don't look too hard at those percentages. And the bottom bit, which is the inequality bit, tells you essentially how you're doing against those measures we discussed. So your learning difficulty patients, your patients with an Asian background, and of course, you know, because of ease of digestion of the data, we have put people of all Asian descent into one category and all patients of Black descent into one category, because, you know, we're trying to make it as easy as possible for all staff of all education levels to understand. So although this is not the correct thing to do, it's sort of a pragmatic approach. But what's startling, I guess, across nearly every single outcome measure, and, there's no p-values, because this is just data that I'm showing you across a population of 372,000 patients, that for Black patients, essentially, compared to every other group, are achieving lower achievement, essentially. Yep. For pneumococcal vaccination, shingles, flu, in over 65s, flu uptake in pregnant women, flu uptake in children, and those at risk who are under the age of 65. Yeah. We do well in patients with learning disability, because you have to remember these particular patients aren't coming in alone. Someone is sort of bringing them, and they understand sort of the vulnerabilities that they may have. So that's why that particular group does so well. And then another one, childhood vaccinations, essentially the same sort of story. So this dashboard resets every year, just so we're clear. It's not a year on year, it's sort of every year. And the financial year starts in April. But again, it's a similar picture for Black patients. It's a lot lower than any of the other categories. So here's some work out of Oxford, and essentially it looked at routine childhood vaccinations in England, but again, based on maternal ethnicity in terms of vaccine take-up. So before I was showing you ethnicity based on the patients actually getting the intervention, but how does maternal ethnicity then affect take-up? And again, it's the same picture for patients of African and Black Caribbean descent. Essentially, they are least likely to have vaccines. So there's poorer coverage there. So what's happening? So to tackle these health inequalities as well. So we also have what's called the Core 25 plus 5. So essentially, it's a national NHS single approach to inform action to reduce health inequalities at both national and at system level. So the approach defines a target population, so the core 20 plus, and identifies 5 areas of focus. So the 20 refers to the 20 most deprived national population, yeah. And then we also have the different areas: maternal care, severe mental illness, chronic respiratory disease, early diagnosis, and hypertension case finding. And then we have the plus, because every area is different. We have lots of deprivation within the coastal areas, as an example. So that would be one sort of area. And then, for example, in inner city practices like mine in London, then you then think about people of Black and Asian ethnicity. So then we think about, you've mentioned about cost, and how much does this cost? And I think that's the one thing that's lacking in primary care. There's not a lot of analysis that looks at the effectiveness of primary care interventions or funding, essentially. But here is an example of one that essentially shows that you can achieve some cost effectiveness for performance related payments. Yeah. And this is another study essentially demonstrating what was called the public health impact score. So essentially, it was looking at what impact does primary care have on mortality. Yeah. So it found that there were 4.7 lives saved for every full-time equivalent GP. But a lot of this data is really at practice level. And therefore, and I think the study was back in 2014. and outdated. And I think it's really important that we come up with and think of new methods to look at the cost effectiveness of these various interventions we undertake within primary care and ensure that not only are these interventions well funded, but they also address health inequalities and don't necessarily perpetuate them. So in summary, I've shown, hopefully, that you understand today that health needs are often greatest in areas of high socioeconomic deprivation, that we need a more equitable resource allocation. And this could be achieved by making use of, well, better use rather, of routinely collected information and big data sets. And the Carhill formula reflects reimbursement of practice workload for the provision of core services. But this is based on, work that I think is outdated. And we need to think about ways in which we can change the allocation formula that reflects a world we live in today. And then also, the Carhill formula really focuses on long-term disease management. Really, we need to shift to thinking about incentivizing prevention. So what's needed? I think what's needed is an improved general practice funding formula that's equitable and cost effective. And we also need to find better ways in which to utilize the richness of primary care data set to deliver targeted approaches. And I think also we need to think about how we evaluate primary care interventions and how those that we then produce don't necessarily perpetuate health inequalities.